Lippincott 2022 stated that preeclampsia is a condition diagnosed during pregnancy when blood pressure is at least 140/90, protein in the urine, and edema in the extremities and face. This blood pressure should be documented at least twice within a 4-hour period. You may also feel signs and symptoms of sweating, blurred vision, dark spots in the vision, and headaches.
Lewine 2023 states that early diagnosis, treating the condition quickly, and monitoring both maternal and fetal status helps significantly improve both maternal and fetal outcomes by preventing the progression of preeclampsia to eclampsia. According to Lewine 2023, preeclampsia occurs when the placenta doesn't attach itself into the uterine wall as deep as it should during the first trimester. Early abnormalities in the placenta can lead to arterial constriction, which leads to high blood pressure. Blood vessels can become leaky, which allows for fluids and proteins to seep through the walls, which is responsible for proteinuria and edema. The cause of preeclampsia is unclear, but it may be related to genetics, immunity, and other maternal conditions such as diabetes and hypertension.
Lewine also stated other risks for preeclampsia, such as hypertension, obesity, diabetes, maternal age being under 15 or over 35, multiple gestations, and being of African or Hispanic descent. In 2023, Carrara and Hong stated that preeclampsia is responsible for up to a quarter of maternal deaths in ethnic populations, such as the Caribbean and Latin populations, followed by Asian and African populations. Blood pressure can be controlled with the use of beta blockers such as labetalol and calcium channel blockers such as nifedipine. Prompt care and routine monitoring can decrease maternal and fetal morbidity and mortality.
Hicks and Tiagi 2023 note that eclampsia can be prevented by administering magnesium sulfate, which reduces muscle contraction and acetylcholine release. Carrara and Hong state that fetal evaluation should include an amniotic fluid index ultrasound, estimated fetal weight, and non-stress tests, as well as a biophysical profile. They note that fetal status may also play an important role in determining delivery versus expectant management of preeclamptic patients.
Lippincott 2022 stated that your baby might be born a little bit smaller than normal. This is because your placenta wasn't giving the baby as much oxygen-rich blood that's full of nutrients. This can slow the growth of your baby and might have a little bit less amniotic fluid. They also mentioned that if you're less than 34 weeks pregnant, your doctor might suggest waiting. If you're between 34 and 37 weeks pregnant, your doctor will talk to you about options and help you decide what to do. If you're 37 weeks or more, your doctor might suggest delivering your baby. If the decision is to wait, your doctor will frequently check you and your baby for any problems. You may need to stay in the hospital for frequent monitoring until it is time to give birth.
Preeclampsia is a hypertensive disorder occurring in pregnancy that, if left untreated, can lead to fetal and maternal distress or, in some cases, death.
This can happen during pregnancy, usually in the second half, during labor, or postpartum.
Lippincott 2022 states that preeclampsia is blood pressure of 140/90 recorded twice within 4 hours, protein in urine, and edema in the face and extremities.
In 2023, Carrara and Hong mentioned that preeclampsia can progress to eclampsia, which is seizures. To treat preeclampsia and prevent the progression to eclampsia, providers will use a medication called magnesium sulfate.
Carrara and Hong 2023 mentioned that blood pressure can be controlled through a beta blocker like labetalol or through a calcium channel blocker such as nifedipine.
They also mentioned that magnesium is a naturally occurring electrolyte in our bodies that helps to maintain normal muscular and nerve functions. This is why magnesium toxicity, we see a depression in our muscular functions, which can result in loss of deep tendon reflexes, respiratory paralysis, and respiratory depression.
According to Carrara and Hong 2023, your provider will administer magnesium sulfate according to the time of your diagnosis, which could be before labor, during, or after, and will be continued for 24 hours after delivery.
In 2023, Hicks and Tiagi noted some normal side effects that can occur when taking this medication, such as tiredness, flushing, confusion, hypotension, increased sweating, and vision changes.
Hicks and Tiagi 2023 also mentioned that when your magnesium levels become too high, you will develop magnesium toxicity. This is when your magnesium levels are out of therapeutic range of 2 to 3.5 millimoles a liter for preeclamptics.
Signs and symptoms of being in magnesium toxicity, according to Shakalipo et al. 2020, are diminished deep tendon reflexes, respiratory paralysis and depression, urinary output less than 30 milliliters per hour, and cardiac arrest.
When you start to present with these symptoms of magnesium toxicity, your provider will stop the magnesium sulfate infusion.
The antidote to magnesium sulfate is calcium gluconate, which may be given if experiencing cardiac or respiratory paralysis or depression.
In 2022, Lippincott mentioned contraindications for administering magnesium sulfate, including severe renal failure, cardiac ischemia, heart block, pulmonary edema, and myasthenia gravis.
Hi, I'm Tyler and this is Matt, and today we'll be discussing the nursing care of a patient on magnesium sulfate for preeclampsia. As stated earlier in the video, preeclampsia includes high blood pressure. It can also include proteinuria, edema, headaches, and many other symptoms. It can put a patient at risk for seizures leading to eclampsia. This can put the mother and the baby at risk. Magnesium sulfate is an essential medicine used for neuroprotection of the mother. A patient is given magnesium sulfate IV. It is started with a bolus. The drug acts almost immediately, but according to Silbert, Flagg, and Kennedy, its therapeutic effects only last 30 to 60 minutes. Therefore, a continuous rate is given after the bolus to maintain therapeutic effects. It may differ on the facility you work at, but according to Hicks and Tiagi, normal magnesium serum levels is 0.7 to 1, and therapeutic levels in preeclampsia and eclampsia are 2 to 3.5. This means that we are making the patient's level of magnesium above the normal range, which can come at some risk. Due to this risk, the nursing care of a patient on magnesium sulfate is intense and requires frequent observation and assessments by the nurses.
Okay, so now I'm going to talk about what should be monitored on a patient who is receiving magnesium sulfate. Okay, so just to reiterate, according to Silbert, Flagg, and Kennedy, the main presenting symptoms of mag toxicity is decreased urine output, depressed deep tendon reflexes, neurological changes, and decreased respirations.
Therefore, before administration, the nurse should listen to lung sounds, take a set of vitals, check the patient's deep tendon reflexes. This can include the knee, the ankle, or if they have an epidural, the bicep or the tricep. The nurse should also monitor the fetal heart rate and contractions.
So the patient is first given a bolus over 20 to 30 minutes, and it is crucial for the nurse to stay with the patient during this time to identify any symptoms of mag toxicity that present themselves. During this period, the assigned nurse should be frequently monitoring the fetal heart rate and contractions, the level of consciousness, the deep tendon reflexes, vital signs, and especially the O2 saturation. So after the initial bolus is given, the patient will then be switched to a continuous rate of magnesium sulfate, which will normally be continued for 24 hours. During this 24-hour period, it is vital for the nurse to continue to monitor the vital signs, the deep tendon reflexes, level of consciousness, and the urine output.
Magnesium is excreted through the urine. Silbert, Flagg, and Kennedy recommends that urine output should be at least 30 milliliters per hour. Respiration should be 12 or more in a minute, and there should be no acute changes in level of consciousness or their deep tendon reflexes. Overall, the nursing care is very intense and requires a skilled and trained nurse to provide this care.
Now we'll be providing recommendations related to accurate nursing assessment, medication administration, and patient safety when giving magnesium sulfate for preeclampsia.
First, we're always going to want to get 2 identifiers for the patient before we give the med. It may differ from facility to facility, but we recommend that 2 nurses check the dosage before the med is given. IV tubing for magnesium sulfate should always be labeled. The medication name should be fully written out rather than abbreviated as MgSO4, as this could be misinterpreted as MsO4, which is morphine sulfate. According to Silbert, Flagg, and Kennedy, the antidote for magnesium sulfate is calcium gluconate. It may differ from facility to facility, but if you're a nurse giving magnesium sulfate, we recommend that you keep a 10 milliliter of a 10% calcium gluconate solution readily available at the bedside in case magnesium toxicity symptoms show up.
So another recommendation, according to Silbert and Flagg 2023, is to never administer mag sulfate as a primary line. Always do it as a piggyback in case you need to discontinue it. That way fluids can continue to run. You also need to use a separate pump and use the closest port to the patient. So another vital check before administering magnesium sulfate is to check to see if the patient has had an adverse reaction in the past in their chart, because if they have, then you definitely don't want to administer it, and call the primary care provider for alternate treatment. So another recommendation we have is to always check the patient's bicep and tricep reflexes if they have an epidural, as according to Martinez et al., an epidural can affect lower limb reflexes and give inaccurate data.
Overall, administering magnesium sulfate can be very risky to the patient. We hope that these recommendations can be used in your nursing practice in providing safe patient care.